Bismillahirrahmanirrahim. Assalamu alaikum. Thank you very much, sir, for inviting me and giving me this opportunity. Today I am going to discuss an important but often overlooked pediatric foot deformity, that is congenital vertical talus. In pediatric orthopedic, we usually see two important congenital foot deformities. One is CTV and other is CVT. But both deformities differ in their presentation, diagnosis and management. No doubt, CTV is more common. Incidence is 1 in 1000 and its management is well established through Ponseti method, as it appears more severely deformed at birth, so treatment started earlier. But on the other hand, CVT is less common. Incidence is 1 in 10,000. Despite deformity is more rigid, it is frequently missed or misdiagnosed even by orthopedic surgeons. Although conservative option is present, but rarely practiced. Another important difference is between CTV and CVT is CTV has no real differentials, but CVT has several differentials. So my focus will be entirely on congenital vertical talus, its clinical features, differentials and management strategies. And aim of my talk is awareness of this condition that is necessary for early diagnosis and better outcomes. So what is actually CVT? As the name indicates, congenital means present at birth. Vertical talus means talus is oriented vertically. In this condition, there is dorsolateral dislocation of talonavicular joint and there is severe and rigid plantar flexion of talus. In this way, deformities develop in hindfoot, midfoot and forefoot. In hindfoot, there is equinus and valgus. In midfoot, the medial longitudinal arch is not present, it is flat, and there is dorsiflexion. In forefoot, there is dorsiflexion and abduction. So you can remember by the word faith, flat foot, abduction, valgus, and equinus. Regarding epidemiology, it is 1 in 10,000, 50% bilateral. Sometimes one foot has CTV while other foot has CVT. 50% is idiopathic and 50% associated with other conditions. Diagnosis is usually clinical by these deformities. You can remember FAVE and see these deformities. But this condition is more rigid, but deformity is less. That's why it is not diagnosed earlier. This condition is confirmed by X-rays, AP view, and especially plantar flex lateral view. You can see on X-ray, talus is vertically oriented, and remember two angles. One angle that is called Mary's angle between talus and first metatarsal. If it is more than 20 degree, then it is congenital vertical talus, and other angle is kite angle between talus and calcaneum. If it is more than 40 degree, it indicates congenital vertical talus. Most important is plantar flex lateral view. It is diagnostic, it is used for confirmation of congenital vertical talus. Differential, very important in this pediatric foot deformity. First of all, CTEV. One foot has CTEV while other foot has CVT. In CTEV, there is cavus instead of flat foot. There is adduction instead of abduction. There is varus instead of valgus. But equinus is common to both deformities. Then is oblique talus. It's very important. Oblique talus is flexible. Oblique talus, in oblique talus there is talonavicular joint subluxation, and this subluxation is reduced on plantar flexed lateral view. But one thing is common in both conditions, oblique talus and CVT, that is tendo-Achilles contracture. Another differential is calcaneo-valgus foot. Our heel is in valgus, but there is calcaneum deformity and it is flexible, and normally dorsum of foot touches the tibia. Another important differential is posteromedial tibial bowing, because in posteromedial tibial bowing there is also calcaneum valgus foot. How you can differentiate between calcaneum valgus foot and posteromedial tibial bowing? You take X-ray. On X-ray there is posteromedial tibial bowing. On the other hand, you see the apex of deformity. Apex of deformity is at lower tibia in case of posteromedial tibial bowing, while it is at the level of ankle in calcaneum valgus foot. Last differential diagnosis is flexible flat foot. As name indicates, it is flexible and medial arch is restored by elevation of big toe. So these are differential which are not present in CTEV. That's why this condition is usually not diagnosed earlier, and deformity is no doubt rigid, but deformity is less severe as compared to CTEV. Treatment is similar to CTEV. It is the statement of Dr. Bobbs, who started Ponsati method treatment for this condition, that CTEV is treated by Ponsati method while CVT is treated by surgical means, and both conditions are present at birth. One is treated conservatively while other is treated by surgically. So then he developed this method. Always start treatment with serial casting. That casting is reverse Ponsati casting. It is similar to Ponsati casting used for the treatment of CTEV. There is a theory of push and pull. Again, in CVT, you first locate the tailor head, but the difference is in CTEV, tailor head is present laterally. You first palpate fibula and then go anteriorly and inferiorly. The first prominent part is tailor head. In CVT, tailor head is present medially. So you feel the medial border and the only prominent part is tailor head. So you push tailor head with thumb of one hand dorsally and laterally, while you pull forefoot with other hand medially and plantarward. In this way, actually, with the passage of time, after 5 or 6 casts, you create equinovarus deformity. It is similar to club foot. You create equinovarus deformity because in this shape, talonavicular joint is reduced. Manipulation for 1 or 2 minutes, then casting, first below knee casting, then above knee casting. This casting should extend up to dorsum of toes, so that there should be no extension at metatarsophalangeal joint, well molding over bony parts, and knee should be in 80 to 90 degree flexion with no internal or external rotation through the joint. It is similar to Ponsati method, but it is the reverse. We create, and at the end of 5 or 6 casts, the final picture is similar to club foot. Now you converted CVT into CTEV. Now the other second step starts, that is, now after this 5 or 6 casts, you confirm the talonavicular joint reduction, and it is done by X-ray. Plantar flexed lateral view, you see the reduction. Then minimally invasive surgery. Here is the difference between CTV and CVT. In CTV, we usually done only percutaneous tendoachilles stenotomy, and it is done under local anesthesia, and after this cast is applied for 3 weeks. While in CVT, procedure is done under general anesthesia, and the last cast is for 6 weeks. First of all, we maintain talonavicular reduction by insertion of K-wires. We already reduced the talonavicular joint by casting. Now we want to maintain this reduction by insertion of K-wire, and after maintenance of talonavicular joint reduction, then we do percutaneous tendoachilles stenotomy. After this reduction of talonavicular joint, we usually do percutaneous K-wire fixation under image intensifier, but this is very difficult. So a small medial incision is made over talonavicular joint, tibialis posterior tendon is identified, and in this way talonavicular joint is identified and capsulotomy is done, and then joint is reduced. After reduction of joint, K-wire is inserted retrograde in the center of talar head. Once the wire tip is buried in the talar head, then reduce the talonavicular joint and insert the wire antegrade until it exits through first metatarsus. After this, percutaneous tendoachilles stenotomy is performed. Now, cast is applied for 6 weeks, and after 6 to 8 weeks, wire is removed, and after this, foot brace is applied. Here, brace protocol is formula of 2. Initial phase is for 2 months, and lengthy phase is for 2 years. It is contradictory to CTV. In CTV, initial phase is for 3 months, and then lengthy phase is for 4 years. Here, it is 2 months initial phase, 23 hours out of 24 hours, and then night brace up to 2 years. And position of brace is neutral. No abduction is required. This is a minimally invasive surgery. Medial incision is given, tibialis posterior tendon is identified, and then talonavicular joint is identified, and then K-wire first retrograde and then antegrade, and then percutaneous tendoachilles stenotomy is done. This a child 3 months old, reverse Ponsati casting is done, and when joint is reduced, then the reduction is maintained by K-wire. If patient is presenting late, then what we will do? Surgically, single stage surgery or double surgery? Usually single stage surgery. Single incision, double incision, triple incision, it depends on severity of deformity. Usually, first of all, we give posteromedial incision, tibialis posterior tendon is identified, and Z lengthening of this tendon is done. Then neurovascular bundle is separated, identify tendoachilles, and Z lengthening is done. Then release ankle and subtalar joint, calcaneofibular ligament, and sheet of peroneal tendon. Identify talonavicular joint, dissect peritalar area, reduce it, and fix it with K-wires. If talonavicular joint not reduced, our approach is a la carte, as per needed. If talonavicular joint is not reduced, assess plantar flexion and adduction. If plantar flexion is less than 25 degree, it means you do lengthening of dorsiflexors. And if adduction is less than 10 degree, then peroneal tendons should be lengthened. For lengthening of anterior muscles, anterior incision is used, that lengthening of tibialis anterior, extensor digitorum, and extensor hallucis longus is done. Lateral incision for lengthening of peroneus brevis and peroneus longus. Also release the lateral subtalar joint through sinus tarsi and lateral talonavicular joint capsule. If still talonavicular joint is not reduced, it means medial column is long, so medial column shortening by naviculectomy should be performed. In naviculectomy, tibialis, because tibialis posterior is inserted on navicular, so after naviculectomy, tibialis posterior should be carefully detached from navicular and advanced to medial cuneiform. If patient is presented late or deformity is more rigid, then salvage procedure should be keep in mind. Calectomy in case of arthrogryposis and triple arthrodesis. If all this fails and there is multiple surgeries, then this is the last option. So, in a nutshell, reverse Ponsati and minimal invasive surgery, then open reduction and soft tissue release, then medial column shortening with naviculectomy, and finally salvage procedure. This is one of my patient, 3 years old, pre-op picture seen from dorsal surface, from lateral side. This is pre-op X-ray. Talus is vertically oriented. Maximum adduction. Adduction is possible more than 10 degree. Adduction is achieved. Plantar flexion is also possible. So in this, only with posteromedial incision, it is possible that we use the talonavicular joint. Posteromedial incision, tibialis posterior tendon is identified. Z lengthening of this tendon is done. Then talonavicular joint is identified, and the neurovascular bundle is identified, tendoachilles is identified, and lengthening of tendoachilles is done. Talonavicular joint is dissected, peritellar area, and then retrograde wire is inserted, then this wire is advanced antegrade. This wire comes out through first metatarsal. All tendons are stitched, repaired. This is the final picture. Lateral view, medial longitudinal arch is restored from dorsal view. This is the cast. Cast is applied for 6 to 8 weeks post of X-ray. Another patient, 5 years old, more rigid deformity. This is a picture before correction.
Sir, go back. Okay. But here, if I look at the first metatarsal, it's jet seams. Mary's angle is 4.
Yes, I agree. I think the key over here is this wire is primarily for the kind of medial joint. So once the wire removes, it will bounce back the first tarsal, and here is equilibrium.
Sir, but clinical picture is evident.
No, but I think the thing that's most important, he has lifted the talus up. He has reduced the talonavicular joint. I think that's the most important thing. You can just forget the first metatarsal, because once the wire is removed, it's going to come back. The main thing is that the talonavicular joint should be in this place, because it has every tendency to go back. There is no spring ligament. All the soft tissues in the plantar side are absent. So what he has been able to achieve is
Very good.
the reduction of the talonavicular joint.
But I have seen few cases with recurrence of the deformity.
Recurrence is very common.
That's more difficult to treat then. So I'm talking how can we address that, why the recurrence of the deformity is there. That becomes very difficult.
Sir, if initial correction is not up to the mark, then there are chances of recurrence. or operatively you have to decide either you should go for another incision for lengthening of other tendons. Main aim is talonavicular joint reduction. You should achieve this reduction.
Sir, you only use tibialis posterior. What about the other flexor tendon in the compartment? You
No need of that tendons release. Sometimes tibialis posterior tendon is no need of lengthening of tibialis posterior tendon. Only tendoachetes there is equinus deformity. Another patient, more rigid deformity. This is pre-op X-ray. Similar, we go with first posteromedial incision. In this patient, plantar flexion is less than 25 degree and adduction is less than 10 degree. This is posteromedial incision in navicular bone. Anterior incision for lengthening of tibialis anterior, extensor digitorum longus and extensor hallucis longus. Lateral, after that lengthening. This is lateral incision for peroneus longus and brevis. After that lengthening. Naviculectomy is done. Medial cuneiform and middle cuneiform shape is similar to cuneiform, similar to navicular. So talus is properly fit into this position. Again, KY is inserted, and this is the final position. Middle longitudinal arch is maintained. Thank you very much. So, take home message is congenital vertical talus is a common pediatric foot deformity as CTED. In this, first diagnose, proper diagnose, don't miss the diagnosis. You should keep in mind differential and always start with serial casting, reverse concentric casting, then minimal invasive surgery. And if patient presenting late, then surgery should be a la carte, as coordinated.
Shahid, I've seen the cases that the anterior skin is shortened, and so if you correct it, then maybe the anterior skin starts to hurt. What do you do then?
Medial column shortening, naviculectomy, left choice. Otherwise, we can also take help from plastic surgery.
Okay. ठीक है।